Dear Chairman, dear colleagues, it is my pleasure to introduce my PhD project. My name is Máté Éliás and I'm a fourth-year resident fellow. My vision is that in the future, for a woman over the age of 40, having a child will be not a question of luck anymore, but the result of a good quality, safe and effective treatment. Therefore, I want to work on novel treatments of infertility. We have two ongoing projects at the moment, both of them in connection with the intra-ovarian use of PRP. Our first project is a meta-analysis to collect and evaluate the so far existing evidence of this field. As the age prolonged when the woman wants to have the first baby worldwide, specialists who are working in the field of assisted reproduction have to face the growing challenge to treat patients with diminished ovarian reserve. Infertility affects around 1 out of 7 couples worldwide. Diminished ovarian reserve is one of the most common causes of death. IVF is the preferred treatment for these patients. As the graph shows, fertility of a woman rapidly decreases over the age of 40. At the age of 45, to having a baby from an own oocyte, even with the help of assisted reproduction, the chance is below 1%. For these patients from the worst prognosis groups, oocyte donation is the only existing chance. But this is a very controversial option. It is not acceptable for everybody because of financial, ethical, and religious reasons. Enhancing the number and quality of the own oocytes could be a good alternative for oocyte donation. PRP is a relatively novel, very promising method, which was successfully tried out in several fields of medicine. In both human and animal studies, after the ovarian administration of PRP, the levels of AMH and FSH improved. Some patients from the worst prognosis group were even able to reach spontaneous pregnancy after the PRP treatment. Despite these promising results, PRP treatment of the ovaries is still not widely accepted in the clinical field. In our meta-analysis, we want to collect and evaluate the data of the PRP treatment of the ovaries. We want to investigate the main fertility parameters and outcomes. We did a systematic search in these 5 databases with this search key. These are our results. We have very promising results. In terms of biochemical pregnancy, 18% of the treated women were able to reach at least biochemical pregnancy, which means that roughly every 1 out of 5 patients get pregnant after the treatment. We have to consider that these patients are from the worst prognosis group. Most of them had a decade of infertility in her medical history and sometimes several unsuccessful IVF treatments as well. The next result is that from the treated women, 11% of the treated women were able to reach successful live births. We have to add the information that this count could be even higher because most of the papers were published before every ongoing pregnancy could succeed in live birth. The most interesting result is the relatively high number of spontaneous pregnancies. 7% of the treated women were able to reach pregnancy after the PRP treatment without any further hormonal treatment. The main fertility parameters showed also very well results. The ultra follicle count elevated significantly after the PRP treatment. In case of IVF treatment, the number of oocytes retrieved and the number of embryos fertilized also elevated significantly after the PRP. we can see favorable changes in the hormone levels as well. The level of FSH significantly decreased in every measured month after the PRP treatment. And the level of AMH, which is the most important factor of the ovarian reserve, significantly elevated in every measured month after the PRP. Our conclusion is that according to the available data, PRP treatment of the ovaries is an effective treatment for women with diminished ovarian reserve. I think more carefully designed RCTs needed with bigger patient numbers and unified protocols to provide more robust scientific evidence. We submitted our paper to the Journal of Ovarian Research, which is a Cuban journal, and it was published in May. Our second project is a protocol of an RCT from the same field. With our meta-analysis, we already stratified the effect of PRP treatment of the ovaries, but question arises, could we enhance the effect somehow, this treatment? The way of PRP treatment is a very simple thing. First of all, we have to collect peripherous blood from the patient. After that, we centrifuge the collected blood, and this how we can separate the fractions, and we collect the platelet-rich fraction. And after that, the administration is via transvaginal ultrasound punction directly to the ovarian tissues with ultrasound guidance. The ASCOT, which is autologous stem cell ovarian transplantation, is a relatively new method. The essence of this method is that the patient get pre-treatment with granulocytes colony stimulating factor, which can mobilize the stem cells, the bone marrow derived stem cells from the bone marrow, and thus we can collect these stem cells from the circulation. We can add these stem cells to the PRP, and we can give the treatment to the patient, as I mentioned previously with this transvaginal punction. In our meta-analysis, we want to, in our RCT, we want to find out that can the ASCOT pre-treatment enhance the effect of PRP treatment of the ovaries. This is the PICO-4 study. In our study, the treated group will get an ASCOT pre-treatment, a PRP treatment after that, and an IVF at the end. The control group will get only a PRP treatment and the same IVF after that. And thus we can compare the two groups. Yes, here it's listed. We want to measure the same fertility parameters like in our meta-analysis. This is how this project is. We will have the meeting in the end of this month to finalize the protocol. PRP treatment of the ovaries is a very promising method with lots of questions to answer, but I think it can help a lot of patients to improve their quality of life. I also want to highlight that it cannot simply support the IVF treatment, but it can help patients to reach spontaneous pregnancy in cases when the patients don't want to get an IVF for some reasons, for example, for ethical or religious reasons. And at the end, here's my quote: "Everything is theoretically impossible until it's done." Thank you for your attention.
I would like to ask from you about your first topic. Why do you have high risk of bias in almost every study?
Okay, well, thank you for your question. It's true, the risk of bias is high almost in every study. The reason of that I think the published papers did not dealt with the confounding factors. Most importantly, they measured the number of biochemical pregnancies. They measured the number of embryos. And everybody knows that for the conception we need a man and a woman as well, and they don't check anything in connection with the male factor in most of the studies. So maybe it can change very strongly the result that the male factor is very poor in some cases.
Thank you very much.
Do you have any data about side effects of the treatment?
Thank you for the question. None of the included studies reported any kind of side effects. The thing is that the treatment is the same as the simple way of IVF treatment. So in every IVF treatment, the collection of the oocytes is we make it transvaginally with a needle with a punction to the ovaries. So it doesn't have a higher risk than have a conventional IVF, which these patients already did several times before this PRP.
Well, I have two questions, but first of all, congratulations to your excellent presentation. Pro primo, what is the clinical importance of anti-Müllerian hormone and Prosecco? Do you know any method, any medication which could help to maintain the ovarian reserve?
First, the importance of AMH is, I think it's very high because most of the protocols decide on whether the patient can start the IVF or she will be rejected because of the ovarian reserve is too low. And if we can rise it from 0.3 to 0.7, it can bring the patient through the cutoff where she can get the treatment. Or sometimes it mainly indicates the results as well. So if we have instead of one oocyte at the end, we have 3. It's a huge benefit.
Yes. So if it is too high or too low, you have to be very careful with the ovarian induction, because if it is too high, there is a higher risk for ovarian hyperstimulation, and if it is too low, then there's a high risk that you can apply the ovarian induction, but maybe once, and after then there will not be further ovulation anymore. So the second question is, do you know, or could you recommend any medication which can keep the or maintain the ovarian reserve?
I don't really know any kind of medication which was proved to be efficient. There are some kind of so if the patient change her lifestyle, finish smoking, can lose some weight, it can improve it a bit. But as I know, maybe take some vitamins.
What about metformin? I mean, low-dose metformin.
I never met with this kind of therapy, but maybe it's work.
Around 100 milligrams a day, it has a beneficial effect to maintain the ovarian reserve. but the patient should start it much more earlier, around the age of 30 and not after 40, of course.
Okay, so it's not something to treat
No,
the patients, it's something
to maintain,
to maintain. Okay.
for elder age the ovarian reserve.
And the indication of that is when we notice
Well,
that AMHs already start to lower, or everybody should take it?
It is recommended to everybody, but particularly for those whose antimullerian hormone is lower than 1.5.
Okay.
Okay, thank you.
One question before I pass on the microphone. Just for the study design, so I understand correctly, these patients were patients that multiple times had failed some form of assisted in vitro fertilization or
Yes.
whatever, and then they did the intervention.
Yes.
For me, I'm trying to think, if I wanted to run and prove something, it's very hard, I know, is you would need to have a placebo arm and PRP arm. I know it's very difficult to do intervention to somebody who has failed, and so, but how do you know? Because it's in your chances of whatever you do. If I give him a foot massage, probably a certain percentage of them may get better. Or not?
The problem is that the administration is via punction with this long needle, and I think there is no committee, ethical committee, which would say, okay, you can puncture the patient with whatever saline, and
I know, but the issue is any type of study you do, I know it's so unrewarding because I know it's impossible, that if you do something and then you make an intervention and then you look at the outcomes afterwards and the patient is its own control, maybe by chances, we know, as you said, the probability second, third time, fourth time just increases because before it was zero. You can only get better, right? Because otherwise they wouldn't go into the study. You know, if you failed before, the next time you're going to get better no matter what. There's a chances you're going to get better.
In this case,
How
I'm
can you
not sure, because one of the most important factor in this case is the age of the woman.
Yeah.
And the time until she gets
worse.
5
Okay.
or 4 unsuccessful IVF, sometimes it's 2 years. And this 2 year can...
Worsen her chance.
Yes,
Okay.
I think.
Congratulations for your presentation. I would like to ask regarding your first project about the best timing to perform PRP therapy during the IVF procedure. And how often?
Thank you for the question. It's still an open question. It was very heterogeneous among the published papers. In some studies, they gave the PRP treatment just before the IVF. So the patient get the PRP, and 1 day later she start to use the hormones for the IVF treatment, or something like this. In some other cases, they gave the PRP, waited for 3 cycles, and after that they started the treatment. So your question is something that we should still answer.
Just an answer to your question, because we are talking about ovarian PRP, but there is another possibility, a uterine PRP, to enhance the implantation of the embryo. And you are right, because we use uterine PRP 2 days before the embryo transfer. But ovarian PRP treatment needs sometimes, as we could see, 1 or 2 months to go to work inside the ovary, and after we start the treatment. Thank you.
So how do you get the data, the variable oocyte count? So this means what?
The count of the oocytes which was retrieved during the IVF treatment.
So if I
It's
understand your mean difference, you couldn't even get 1 more.
Yes, but the thing is that these patients with this very bad ovarian reserve, in most of the cases, have 0 or 1 or 2 oocytes. So in this level, having almost 1 more is a huge difference. So it's almost double the amount of oocytes. So it seems to be low, but in
That's
their
what I'm
life, it's
asking.
a huge result.
It's a clinical margin question again. That's why I'm asking. Okay. Thank you.
Thank you.